Today we'll be listening to Dr. Petrylak speaking about advances in the treatment of metastatic bladder cancer. Thank you very much. Thanks.
Thank you and good morning. So it's a pleasure to be here today, and should I use this?
Yeah, absolutely. Just a moment. It's going to go right in your presentation.
Okay. Thanks, Jody. So thank you. It's a pleasure to be here today, and I'm really proud of the work that we've accomplished and the collaboration between medical oncology and urology. It's really been a great 6.5 years since I started, and I'm going to be talking about some of the progress we've made in the treatment of metastatic bladder cancer. So how do I move forward here? No, just do it this way. So these are my disclosures. I also root for the Mets, the Jets, and the Rangers, so if that's relevant. Bladder cancer's come a long way, and this is Alan Yagoda. Alan Yagoda was really the preeminent GU oncologist of the 1980s and early 1990s. He was the person who invented the MVAC regimen, and I always put this picture up to remind myself of the fact that we've come a long way since that period of time. And in fact, we had a long gap from the time that MVAC was developed to the time that we started seeing responses with immune therapy in metastatic disease. And Alan really was the inspiration to a lot of us. He trained me, Dean Bajorn, Howard Shear, Cora Sternberg, amongst others. And really, we miss him dearly. And it's hard to believe it's more than 20 years since he passed away. So bladder cancer is the fourth most common cancer diagnosis in men. Overall, it's the 5th most common cancer diagnosis, the 12th most common cancer diagnosis in women. And interestingly, the 4th most common diagnosis in the state of Connecticut. For some reason, Connecticut has a higher rate of bladder cancer than the rest of the country. About 80,000 cases will be diagnosed in 2019. That will lead to about 17,000 deaths from metastatic disease. It's 7% of all cancers and 3% of all cancer deaths. And I think the important thing in this health economic era is the fact that this is an expensive tumor to take care of. As of 2001, and these numbers have actually gone up since that time, it costed $187,000 per patient to treat a patient from diagnosis to death. And with the advent of the checkpoint inhibitors, that's going to be a larger number. The ratio is 3-to-1 from male to female. The peak incidence is in the 60s. And the majority of these patients are urothelial carcinomas. We've gone through a revolution in the last 5 years in bladder cancer. As we know, for superficial disease, we have BCG. We're now starting to look at checkpoint inhibitors for the treatment of superficial or non-muscle invasive disease. GemCis or MVAC were used as metastatic for the treatment of metastatic disease. We now have 5 checkpoint inhibitors that are approved for this. And I think the exciting area, everybody's talking about the checkpoints, but the exciting area, which we'll talk about at the end of the talk, is the use of targeted therapy in the treatment of metastatic urothelial cancer. And that's, I think, going to complement nicely our data with checkpoints. So in the 1990s, the prognosis was dismal if you had metastatic disease. Even if you got MVAC, your chances were 17 in 133 if to survive 3 years, and only 9 patients of that 133 patient cohort survived 6 years. So clearly, we were curing a very small fraction of patients. These tended to be patients with lymph node only disease and good performance status, but the problem was taking care of patients with visceral or liver metastases, and this is where really the high death rate comes from. So there were a number of approaches to try to improve the response rate of MVAC. One, of course, is to dose intensify, and this is the dose-dense MVAC regimen that we're now using as standard therapy for neoadjuvant treatment. Basically, what you're doing is condensing the MVAC regimen over an 8-week period rather than giving it over a 4-month period. The overall cycles were monthly. This is giving it every other week with growth factor support. And Cora Sternberg did a randomized trial looking at this regimen in metastatic patients. Interestingly, you did see less neutropenia because of growth factor support, about the same amount of thrombocytopenia, and the response rates seemed to be higher overall, including complete responses. That did not translate to a significant difference in improvement in the hazard ratio. This is a bit of a misleading survival curve because the numbers are small as you go towards the end. But generally, dose-dense MVAC is felt to be similar to standard dose of MVAC, and we now use this in neoadjuvant therapy. In fact, we tend to see a higher complete response rate with dose-dense MVAC. It allows the surgeon to get the patient to the operating room more rapidly, and I think it's actually better tolerated overall. Gemcitabine cisplatin is also an alternative standard of care for metastatic disease. And as we see here, the survival, median survival is about 15 months. It was compared to standard dose MVAC. My contention would be that if you did this trial in the modern era, you probably would see the similar toxicities between the two different arms, because neutropenia was the difference in those particular treatments, and that's the reason why we use GemCis over standard dose MVAC in the metastatic state. There have been other attempts to improve the MVAC regimen. Paclitaxel was added to the GemCis regimen. Paclitaxel was added to the doublet in a randomized trial that was done in both the United States as well as in Europe. Joaquin Belmont led this. And although there was a 14% reduction in the risk of death overall, it was non-significant. And I think had this trial been powered a little bit differently, it would have been a positive study. But nonetheless, GemCis is still considered the standard of care. So let's talk about what's new and exciting in bladder cancer. This is actually not so new anymore, the use of checkpoint inhibition therapy. So we know that cancer cells can have mutations. These mutations make them look foreign. So the more mutations you have, the better chance you have of responding or having a T cell recognize a cancer cell as being foreign. Cancer cells can evade these particular immune pathways by expressing PD-L1, and this basically will, almost like a cloaking device from Star Trek, you'll shut off the T cells from recognizing the cancer cells by blocking this particular pathway. So we want to reactivate the immune system by using monoclonal antibodies that are either directed at the PD-L1 receptor or at the PD-1 ligand. And there have been numerous trials done on other solid tumors, in bladder cancer, in lung cancer, melanoma, that show that you can see dramatic responses with PD-1 or PD-L1 inhibition. As of this date, there are 5 checkpoint inhibitors approved for the treatment of metastatic urothelial carcinoma. 2 are approved in the front line, and these are for patients who are not eligible for cisplatin. Those include atezolizumab and pembrolizumab, and the other 3 are approved only in the second-line state, in other words, after failing initial chemotherapy. And that includes durvalumab, avelumab, as well as nivolumab. So in the front line, there were 2 approvals. These were both in 2017 or in the spring of 2017. Atezolizumab was approved first, and then pembrolizumab. Now, these were approved based on an accelerated pathway by the FDA. So all you had to demonstrate was phase 2 data, not phase 3, but you needed a confirmatory phase 3 trial to show that there was activity. And this is a way of getting the drugs into our hands more quickly. So how do we define a cisplatin-ineligible or a patient who should not undergo treatment with cisplatin? These are patients, of course, who have renal insufficiency. They may have cardiac dysfunction, which can preclude hydration, possibly also third space accumulation of fluids. Their performance status may preclude full doses of treatment that may predispose them to neutropenia. And there really are not standard criteria. It's almost like the definition of pornography from the Supreme Court. You know it when you see it. You're shifting the goals from palliation of symptoms rather than the response and survival. That's now changed with the checkpoints. And in the past, we've used single agents as well as combination carboplatin doublets. The survivals in these patients generally turn out to be about 9 months. And now, of course, immune therapy is used as first-line treatment for most of these patients. So the IMvigor210 trial was a 2-cohort study. I want to first talk about the platinum-ineligible patients who had predominantly urothelial histology. We looked at PD-L1 staining in the tumor to see if we could predict who was going to respond. And these patients could have no prior treatment except adjuvant and neoadjuvant therapy for more than less than 1 year since the operation. And also they had to have cisplatin ineligibility as defined by renal function, hearing loss, or ECOG performance status. So this is cohort 1. As we can see here, number 1, there is no correlation between PD-L1 staining and overall survival, which was surprising because, as we'll see from the phase 2 data, that seemed to correlate. The objective response rate was 23%. The median survival from this phase 2 study was about 15 months. And that's better than what you would expect with gemcarbo, which I mentioned before is about 9 months. So that led to the approval of atezolizumab in this situation. Pembrolizumab, which is different from atezolizumab. Atezolizumab is a PD-L1 inhibitor. Pembrolizumab goes after the ligand, which is PD-1. And this is approved for numerous solid tumors. Very similar entry criteria. The only difference is they took class 3 congestive heart failure patients in this trial. Again, the drug is given in those patients who had less than 1 year or failed chemotherapy in the first line. And we see a very similar objective response rate of 29%. And now the way we look at the sequence for patients who are treated in front line, we talked about MVAC before, cisplatin-based chemotherapy, then they get a PD-1 or PD-L1 inhibitor, and then they go on to single-agent chemotherapy or clinical trial. Carboplatin was used in the past. They go on a checkpoint inhibitor and then single-agent chemotherapy, but now with this data, we're moving this up front. Frontline therapy is considered to be pembrolizumab or atezolizumab, and then single-agent chemotherapy. You also don't look at biomarkers if a patient really has significant comorbidity. And again, these are the data that I summarized in the data from before. And the front line is, or the first column is gemcarbo from a phase 3 trial from Europe. And you see a median survival of 9 months. It's about 16 months with atezolizumab, and it's not yet been reported for pembro. So this is where the confusion starts. So the FDA put out an alert last year from 2 randomized trials that were being performed looking at upfront checkpoint inhibition therapy combined with chemotherapy versus upfront checkpoint inhibition therapy. So basically, it's either checkpoint plus gem-cis or gemcarbo versus chemotherapy. So what they found was in trials both with pembrolizumab and atezolizumab that if you have low PD-L1 expression, your survival is worse than if you get chemotherapy, which flies in the face of what we saw with the phase 2 data. So now what we're doing, all of these patients, if they're medically reasonably fit, is we're checking PD-L1 status. And if they're low, they go on carboplatin-based chemotherapy or clinical trial. And then if they're high, they can go on checkpoint inhibitor. So these are the trials that are starting to look at combinations of chemotherapy plus checkpoint inhibition therapy up front. And these are the trials I mentioned before. They're all being compared to standard arm, which is gemcitabine plus a platinum, and atezolizumab, pembrolizumab, durvalumab, pick your poison. These are being combined with chemotherapy. So I think we'll see within the next year whether the standard of care will be chemotherapy plus checkpoint versus checkpoint alone, or versus chemotherapy alone. And I think that if lung cancer is showing us any data, that's probably what the standard will be. So second-line disease, approval started in May of 2016. We put some of the first patients on atezolizumab at Yale at that particular, actually February of 2013 was when we first started the studies. And May of 2017, pembrolizumab was approved. So the IMvigor210 trial looked at atezolizumab in patients who had prior platinum-based therapy, and 310 patients in this cohort. They just had to have progression. And so here's where the contradictions start to happen. This is survival based upon PD-L1 stain. So the upper curve are the PD-L1 positive patients, the lower curve are the PD-L1 negative patients, or the low PD-L1 expressors. So patients who express PD-L1 do better in the second line. Why is there contradiction? Well, we'll talk about that when we talk about markers later, but there are reasons why this may occur. So there were 2 cohorts of patients. This is data that we just published about a year ago in JAMA Oncology. This is our experience with patients who long-term survival in patients in second line who were treated with PD-L1. And we found that the objective response rate was 50%. We have patients who were living more than 2 years in this particular situation. Remember, median survival was about 6 to 9 months in these patients. And again, we saw the same correlation between PD-L1 status and overall survival. The overall survival in this trial, median survival, was about 12 months overall. Now, one thing we identified from the study was the fact, as we've seen as a persistent theme with metastatic disease, the patients who have disease in the liver who do worse, patients who have good performance status do better, and patients who have nodal disease actually do better as well. So these are the ones that we would think about doing just a single checkpoint trial or single checkpoint up front, the more aggressive patients we're looking to do combination therapy on. The question with these checkpoints is how long do you go? And it's very, very stressful for the patients, particularly if they've had a dramatic response to treatment and they're getting this treatment every 3 weeks. Do I continue on with what I'm doing? And what we tell our patients is, yes, as long as you're tolerating the drug, we'll keep on going. And obviously, with an expensive drug like this, this has got a lot of financial toxicity. But the issue is side effects. And as we see from our data from the first 2 years of treatment, the majority of adverse events occur within the first year. And when you start getting out to year 2, you're really not seeing a lot of AEs with these particular patients. And again, these are fairly well-tolerated drugs. So what about a randomized trial? So this is the way that we can go forth with getting drugs approved. And of course, with an accelerated approval, which is where the second line went, because that's phase 2, you need a confirmatory phase 3 to go forth with full approval of the drug. So this was the IMvigor211 trial, which took Atezolizumab and compared that to standard chemotherapy, vinflunine in Europe, paclitaxel, docetaxel. As I said before, these all have survivals about 7 to 9 months. Now, this trial was doomed by its design. So it's a 3-layered study. So what the assumption was, and this was the shortcut in trying to get this drug approved, was that if you were positive in the PD-L1 patients, then that's the first level of test with this particular study. You had to be positive there. And that, of course, is stacking the deck. At least they thought it was stacking the deck at that time. Then if you were positive on the first group, you went on to the second analysis, which was IC123s, which is weak and strong staining for PD-L1. And then finally, the overall survival was looked at in all patients. If you failed any step along this chain, the trial was terminated. So unfortunately, what happened was there was no difference in survival for the PD-L1 positive patients. And we were all shocked by this based upon the phase 1 and phase 2 data. So why did this occur? Well, there are different ways of looking at PD-L1 staining, as we'll see later. But with Atezolizumab, the test that's used checks PD-L1 staining on the immune cells. There is also PD-L1 staining on the tumor cells. It's been shown that tumor cell staining is prognostic for survival, and immune cell staining is predictive for response. So you've got a prognostic factor mixed with a predictive factor, and that's why I think this particular trial failed, because they didn't take into account that PD-L1 patients actually probably did overall a little bit worse. So then the second population, again, not significant, and they actually hit as a significant difference on the overall patients. So they've done it the right way, and just taken all patients as a whole, they would have had a positive study. So this is a negative trial because of the rules that were set up. Nonetheless, there are people who argue that because of the reasons I mentioned before, that it was poorly designed. We all feel that these checkpoints are about the same as far as their survival goes. Compared with single agent taxane, PD-L1 or Atezolizumab was better, but that's a subgroup analysis. When we start looking at the other agents, the volume, and I'm going to rip through these pretty quickly because they're all about the same. This is a PD-1 inhibitor. This is from a phase 2 study. This is what the approval was based upon, Checkmate 275. About a 9-month survival with nivolumab. Durvalumab, which is a PD-L1 inhibitor. This is again from a phase 1 study. This one, with their method of analyzing PD-L1, did show a difference in outcome based upon PD-L1 staining. You got a survival of about 18 months, an objective response rate of about 18%. And then based upon this, we're doing a phase 3 study in the upfront setting, which is actually now closed, and I hope will be read out within the next 6 months, of durvalumab plus tremelimumab. That's a CTLA-4 inhibitor. So that's basically maximal immune therapy, comparing that to durvalumab monotherapy alone versus standard chemotherapy. And this is in the frontline setting. We actually put a couple of patients here. We're also on the steering committee for that. The Javelin study looked at durvalumab as well in patients with metastatic urothelial carcinoma. No correlation with PD-L1 staining. Survival was 7.4 months, and again, about a 20% response rate. So there is a positive phase 3 trial with checkpoint inhibition therapy. And interestingly, this is a trial that was designed, again, not using PD-L1 status, but we were looking at that after basically to correlate it. We were not using this as a stratification factor or a statistical factor. So compare pembrolizumab to standard of care chemotherapy in the same population of patients with atezolizumab, and lo and behold, there was a survival difference, mean of about 12 months for those patients treated with pembrolizumab. It's 10.3 months here, but the updated data is 12 months, and chemotherapy was 7.4 months. Now, why is there a disconnect between progression-free survival and overall survival? Because you don't see a significant difference. The majority of the survival benefit is derived from those patients who have long-term responses. So if you respond, you're going to tend to be durable. And so you may see differences in PFS or no differences in PFS because the long-term survivors are the ones who are driving the curve here. And then the second issue, too, is that we do see responses that occur past progression. And this is one of the interesting things about immune therapy. You can see a flare-up of a tumor cell because it expands with lymphocytes. It actually looks by RECIST criteria that's actually getting worse. So the important thing is you got to look at your patient. Are they feeling better? Are they responding in this particular situation? Do you think that they're clinically better? Then you go on for another month and you repeat the CT scan. If not, they should go on to salvage therapy. So what are some of the future directions? And I really am going to need everybody's help here. I mean, we have done great collaboration over the years. You know, Peter has really led a phenomenal collaborative effort, interdisciplinary effort between our different departments. And this is an area I think where we really can make a big difference. Because in non-muscle invasive bladder cancer, this is now where the forefront is with PD-L1 inhibition. And one trial, the trial that we're doing in the Southwest Oncology Group is looking at atezolizumab in those patients who are BCG refractory. And this is giving atezolizumab as a systemic treatment, and we're monitoring these patients forward. We have had this trial open for about 2 months. We have unfortunately not put any patients on that. So I want to be sure that people are aware of this study because this has the potential of preserving somebody's bladder if they get a complete response to atezolizumab. So that may make a difference in the patient's quality of life.
So talk about that, Dan. Where can we, the patients here, can we get them?
Here, we're open here. Pat and I are running that together. Pat's the PI on that. So Pat and I are basically, I'm treating patients with atezolizumab. Pat is doing all the evaluations in this particular situation. So all you have to do is refer patients to Pat. John's also a co-investigator on the trial as well. So any patient who is eligible for the study, we would be happy to get them on that. I think it's going to make a big difference.
So basically, and we can define it as they come in non-muscle invasive, you treat them with BCG.
Right.
And then when it's surveillance cystoscopy 3 months later, they have recurrence of disease,
right.
We would submit them.
Exactly. So let me see.
There should be a lot. That should not be hard.
Yeah.
So the people that you're considering for for salvage intravesical chemotherapy, like you're giving gemcitabine, docetaxel, thinking about doing a radical cystectomy for BCG unresponsive disease, those people are all the ones that should be screened for it. We've had a few people who would met inclusion criteria but were excluded for other reasons, like they had an autoimmune disease or had a concomitant other malignancy that's prevented them from enrolling. So it's a great trial. It's a great opportunity for our patients. To me, anyone that you're considering giving a therapy other than BCG to, you're thinking, oh, let's have maybe we'll give BCG interferon or something. At least get them screened for the trial. It's also open at Greenwich.
Right, it's open at Greenwich as well. In the VA.
And then what about L&M?
It's not open in the care center. We're trying to open in the care centers. I guess we could open it there as well.
No, but open it or actually just let the Joes know about it.
Yeah, we could be. I'll let Joe know.
About
Yeah,
down, right?
exactly.
So Pat, will you do that?
Say that again.
Let Joe and Joe know about this.
Yep.
Because I think up at L&M, the care center up there, what's Waterford? Is that where it is?
I believe so, yeah.
So if they can't do it at the center, they can send the patient down here.
Yep. And all the urology work can be done there. It doesn't have to be here.
So this is the reason why I'm so excited about this. This was presented at the ESMO meeting this past fall by Dr. DeWitt. These patients were patients who had BCG refractory disease. These are some of the clinical characteristics. Look on the right column. About 13% had CIS with T1 disease, about 15% with CIS with high-grade TA, and about 70% were patients with CIS alone. So this is the complete response rate. It's 40%. Now, I'm going to be very cautious about this because the follow-up is very short. Median follow-up is about 7 months at this particular point. So what we really need is the long-term follow-up. But at least in this particular situation, we're seeing responses in patients who are BCG refractory. So again, this is why I'm so excited, and I think this is a great opportunity. Also look down below, progression to T2 disease. Nobody progressed to T2 disease. So we're also trying to look at improving the primary checkpoint inhibition therapy right at the beginning. So the ipilimumab, which is an anti-CTLA-4, which is a different pathway of checkpoint inhibition. This is approved for metastatic melanoma. Basically, you're shutting down two parts of the immune system. If you add IPI at the time of progression on nivo, not particularly a great response rate, 10%, but John Rosenberg has presented data looking at the combination in different dosages in patients in the second line, and has found that there does seem to be a higher response rate with 1 milligram per kilogram of IPI and nivo as opposed to the higher doses, and an overall survival of about 15 months. Got to be careful with interpreting this. This is a randomized phase 2, so clearly needs better confirmation. And it does seem to work better in those patients who PD-L1 high. We have open adjuvant trials. So we were participating in the Atezolizumab study, which is closed. The trial that is open here is the Ambassador study, which is a cooperative group study that is looking at pembrolizumab in the adjuvant setting. So anybody who's had a radical cystectomy, if they've had neoadjuvant chemotherapy, they've got to have at least T2 disease. If they've not had neoadjuvant chemotherapy, they can be T3, they have to be T3 or greater at cystectomy. They're randomized to receive pembro or observation. Observation would be a standard of care for those patients who have or platinum eligible who have had neoadjuvant chemotherapy. And then also, we don't believe that carboplatin is an appropriate drug to give as adjuvant therapy. So it would be appropriate to put a patient who's platinum ineligible, who's had a cystectomy, on this adjuvant trial as well. So this is accruing nationally a little bit more slowly than I would like it, but it's going forward. Upper tract is a small proportion of patients who are, so I don't know if the upper tract portion has been filled yet. But I think it's about 10% of patients who have been permitted. We had the same trouble with atezolizumab. The upper tract section actually shut more quickly than the lower tract section. Neoadjuvant study, we're about to open up a durvalumab, tremelimumab chemotherapy trial that hopefully will be open within the next 6 weeks or so, giving checkpoint plus chemotherapy up front. Just move forward here. SWOG is looking at a combination radiation therapy atezolizumab study for those patients who are refusing cystectomy, and it's giving chemotherapy along with atezolizumab, and then they're getting the atezolizumab for a year along with their radiation therapy. And again, the primary endpoint is survival, so we will open this trial once it's open. I mentioned biomarkers before. It is a little bit confusing. We do see a higher response rate. It may be linked to overall survival in patients with urothelial carcinoma. However, there are multiple assays, and we really need other biomarkers. And this is really, I think, the crux of the whole problem. The SP142 assay, as I mentioned before, looks at PD-L1 staining in the immune cells. So you can see strong immune staining on the upper portion left. The other two antibodies, SP263 and 22C3, will look at both tumor as well as immune cells. So again, right there, you've got a potential discrepancy between what you're seeing in staining. In fact, David Rim has looked at this in lung cancer, and I believe he found that there was about a 75% concordance between all three antibodies. So a quarter of the patients, they're going to differ in what their answers are. So again, there are problems with the methodology.
So,
Yeah.
You know, David Rim, is he using like the Cycloth machine and doing all this stuff, multiple?
Yep. So he's looked at this in lung cancer in that particular respect. He's looked at equivalent cuts, and they blinded each other in terms of what the PD-L1 staining is. And again, they had about a 75% concordance. The one that seemed to had the best correlation overall was the SP263, but again, this is where we've got the problems, and this is why this FDA alert was so confusing to everybody. Mutational burden, as I mentioned before, is something that correlates with overall response to immune therapy. As you see, bladder cancer is on the right portion of the curve. Prostate cancer is in the middle, and although we're not going to talk about prostate cancer, we are looking at some very, very unique immune treatments in prostate cancer. Perhaps someday I'll get a chance to present that data to you, but it's a very, very different ballgame in prostate cancer. the patients with DNA repair mutations are the ones who tend to respond to checkpoint therapy. So what about thinking about this issue about mutational burden in terms of the types of histology and also in terms of PD-L1 staining? So we can see that if you look at both luminal and basal, those patients who are responders tend to have the higher mutational burdens. And if you start putting PD-L1 staining and mutational burden together, you start seeing a separation out of the curves in favor of high mutational burdens and high PD-L1 staining. In fact, with Atezolizumab, it seems that the luminal type 2s are the ones that respond the best. This may be related to the fact that these are the ones that are the inflamed phenotype as represented by the center. They have high levels of T cells. They also have high levels of stromal gene expression. Level of,
So Dan, for the residents, just describe luminal and basal.
So in breast cancer, you can see on the left, luminal, basal cells are the ones at the bottom portion of the urothelium, as you see from the little cartoon on the right. Luminal is more in the close to the bladder or where the urine is, or the lumen of the bladder itself. The basal cells are thought to be where the stem cells are and where the urothelial cells are up along that particular continuum. So there are different types of luminals based upon gene expression. The basal cells are the ones that tend to respond to chemotherapy. The luminal type 1 and 2s do not respond to chemotherapy, and that's been shown from neoadjuvant studies. The interesting thing here is the PD-L1 staining is in the luminal type 2s, which are not chemo-responsive tumors. So the differences are that the luminal type 1s don't have T cells. They are the immune desert, and they have low levels of T effector cell expression. The luminal inflamed ones have low stromal gene expression, and the basal ones are the ones that are immune suppressed. They have high levels of T cells and high levels of stromal gene expression, which inhibit the T cells.
I have a question.
Yeah.
How, are the tumors really split to base on the level of the urothelium? Because I thought it was complete replacement of the urothelials. I'm a little confused. Is there a focal tumor within the multi-layered
It's actually gene expression.
Gene expression. So there's
effects.
nothing to do. Okay, so it's based on where their primary origin, based on the genotype of the cell.
Exactly.
Not the anatomic location.
Right.
Seen
Exactly.
on
That's
the-
where it was.
Okay.
I should have been clear about that. Okay. So, and the difference also between PD-1 and PD-L1 may be that you're seeing higher response rates in the luminal type 1s than the 2s, but these are small studies, so it's hard to really overall determine that. So where do we move on from here? The last portion of this talk, I'm going to be talking about targeted therapy. Unfortunately, only about a quarter of patients really benefit from checkpoint inhibition therapy. So 3/4 of our patients are not going to respond. So how do we move forward, and how do we design treatments for these particular types of patients? Well, the one thing as opposed to leukemias or liquid tumors is there's really no gene pathway to hang your hat on for all patients. Urothelial carcinoma is heterogeneous. There are multiple pathways that are activated, and unselected trials can lead to very, very unlikely results as far as responses are concerned. And I don't know how many of you were Tom Lynch's talk the other day, but Tom was basically saying that we're now going to only start approving drugs, and or the fastest way to approve drugs is using targeted therapy or molecular phenotypes to select patients. So pathways that we know that are activated in urothelial carcinoma include PI3 kinase, TSC1, the PTEN pathway, TSC2, the FGFRs. Those are, I think, it's an exciting pathway, which there may be a drug approval in the next year. And also the EGF receptor pathway, which has been a bit of a disappointment. So TSC1 mutations are seen in urothelial carcinoma in about 8 to 15% of patients. And the first key that showed us the TSC1, and again, this is with the mTOR P10 pathway, the first key that showed us that there may actually be a validity to this approach was a patient who was treated at Sloan Kettering on a trial of pazopanib combined with an mTOR inhibitor. And what this patient had was really a dramatic and remarkable response to the treatment. And she had an activating mutation in mTOR, and she actually had a response that lasted more than 2 years. So based upon these particular responders, we're designing trials based upon molecular subtypes. So Joe Kim at our institution is looking at TAC228, which is a dual TORC1, TORC2 inhibitor. So this is why we phenotype all of our patients who come into the clinic. And this drug targets mTOR like everolimus, but it's supposedly more active. And we're selecting patients based upon TSC1, TSA2 expression, again, about 10% of our patients. And we're trying to accumulate 25 patients. We're about halfway there in this trial. It's slow accrual a bit because we're selecting our patients based upon phenotypes, and these are not common, but these may be where we're seeing the advances.
So Dan, when you say that woman had a 2-year durability, did she begin to fail again?
She began to fail
And
again.
when they fail, do they then have another alteration that, so it's another pathway?
It's another pathway that either the cells are selected, because remember, these are heterogeneous.
Right.
So you may be able to kill off all the mTOR positive cells and you're left with FGFR3.
Right.
Okay. So the question is going to be then, what do you,
do you hit it serially or do you?
so you have to serial biopsy these patients. So the question is what, I think the real interesting thing is going to be what's the hierarchy? You know, what do you inhibit first? Do you go after FGFR3? Do you look at the overall quantitative expression of different oncogenes?
And what about using multiple agents up front?
Right, exactly. So you're going to phenotype these patients to see what their phenotypes are. It may be appropriate to give 2. You may not be able to give 2 because of toxicity. So it's going to be a very, very interesting little series of studies that are being done with these patients. So FGFR3, otherwise known as fibroblast growth factor, is another tyrosine kinase that's involved in proliferation, differentiation, and steroid biosynthesis. There are mutations that are seen in urothelial carcinoma. These have been looked at both in primary tumors as well as in metastases. It's about 10 to 20% in metastatic disease. It's actually, interestingly, even higher in non-muscle invasive disease. Nobody's really not sure why that is, but there are a variety of different FGFR complexes that are being evaluated in patients with urothelial carcinoma. These patients all being pre-selected. So this is a study that recently was presented at the ASCO meeting. BLC 2001 is a drug that that basically attacks fibroblast growth factor, and the otherwise name for the drug is ergofitinib. Patients in this trial had to have FGFR3 expression, mutations, and these patients initially were randomized to different dosages, and they established 8 milligrams per day as the phase 2 dose. In these selected patients, the objective response rate was 40%. Again, remember that in second line, it's much, much lower. It's about 10% overall. Shrinkage was seen in 76% of patients, so that's just the overall response rate, and the survival was about 14 months in these patients. Now, the interesting thing is that these drugs are not without toxicity, hand-foot syndrome, dry skin, and this drug is actually titrated based upon phosphate levels. So you check your phosphate levels. If your phosphate levels are normal, you can dose escalate. Hyperphosphatemia can actually be a side effect, so we watch for this carefully and adjust our doses accordingly. This was published within the last year. This is some data that we were participating in, another FGFR3 inhibitor, again, about a 20% objective response rate in selected patients. And the other thing that we found that's very, very interesting is that FGFR3 expressors don't respond to immune therapy. So in a very, very small series, in 20 patients, only one of those 20 patients responded. So we actually have looked at combining checkpoint therapy with FGFR3 inhibition. And this data will be presented at ASCO, hopefully this year if the abstract is accepted. We also looked at anti-angiogenesis as a target for metastatic disease. Ramucirumab is a combined VEGFR1, VEGFR2 inhibitor, and there was sufficient rationale for looking at this drug in urothelial carcinoma based upon cell line data. There was synergy with docetaxel, which we saw before was a default standard of care for second-line disease. We also see expression in the tumor cells, but not in normal urothelium. There's a higher level expression in metastatic specimens. So the RANGE trial, which we ran, it was published in Lancet last year, combined ramucirumab with docetaxel, compared that to placebo plus docetaxel in patients who had failed first-line chemotherapy. This trial had the unfortunate disadvantage of being designed while the checkpoint area was developing, so we don't have a large number of patients who've been on checkpoint inhibition therapy. The standard types of patients that we see with second-line metastatic disease, predominantly visceral and liver disease, and we did see an improvement in time to progression, but not a significant difference in overall survival. The trial, this was a secondary endpoint. This is our PFS data. Again, we see, this is a subgroup analysis. We did see a survival difference that was significantly different in the primary bladder versus those patients who had other primaries, such as renal pelvis tumors. So if this would have been bladder-only trial, would have been positive. And we did confirm our progression-free survival data at the final analysis. So unfortunately, this is not moving any further, despite the fact that we're seeing about a doubling of the objective response rate with the combination therapy. Where I think we're most excited is this era of targeted therapy. So this is a drug, Enfortumab Vedotin, which I've been working with since about 2012. This is an antibody drug complex. So this is a way of delivering a smart bomb to the cancer cell. So as you see on the left, there's an antibody complex comprised of an antibody to nectin. Nectin is expressed in 47% of urothelial carcinoma specimens. And 4 complexes of MMAE, which is an antitubular agent like a taxane. This complex enters the cell and is then cleaved by the lysosome. The MMAE is liberated and it causes its effect on the cancer cell and causes the cell to apoptose and die. If we use this level of MMAE in free drug, we basically kill the patient either with neutropenia or severe nausea. Also peripheral neuropathy, since it's an antitubular agent, that's just another side effect. So when this drug was tried in phase 1 at dosages, they couldn't really achieve clinically meaningful responses. So this is a way of overcoming that. Nectin is not expressed in normal cells. It's expressed in bladder cancer, lung cancer, and ovarian cancer. So that led to a phase 1 study in these particular tumor types, which we actually opened here in about 2013. This took patients on an escalating basis with urothelial carcinoma. We also collaborated with the GYN oncs and with patients with ovarian cancer in this trial. And we eventually got to a phase 2 dose of 1.25 milligrams per kilogram. This is a histogram looking at nectin expression. We initially had nectin expression as an entry criteria. We dropped that because, as I said before, 97% of urothelial specimens expressed nectin. So these are our patients with metastatic disease. The majority of patients came off the trial due to disease progression. Only about 20% of patients came off due to safety issues. These are our demographics. Typical second-line patients, predominantly good ECOG performance status of 0 or 1. Hemoglobin levels, which is a poor prognostic factor. Low hemoglobin in about a quarter of patients. And about 48% of patients having disease in lung, about 29% of patients having disease in liver. These were predominantly patients who failed checkpoint therapy. So again, this is where we're looking to position this particular drug. Fairly well tolerated. We've actually had patients who've been on this drug now for more than 2 years. That is where peripheral neuropathy turns into an issue. We have to dose reduce or spread our doses out. But fatigue, alopecia, decreased appetite, and peripheral neuropathy, rash are seen. The majority of adverse events were mild to moderate. And these are some of the adverse events regardless of treatment attribution. We did have a toxic death due to sepsis on this particular trial. We also have to monitor glucoses in these patients. If it's above 250, we don't treat. These are our responses. Overall, confirmed partial response rate of 37%, confirmed objective response rate of 41%. We have 4% CRs. And we have a CR in liver that is now probably one of the worst cases of urothelial carcinoma I've ever seen. She's been a CR now for about 2 years, and she's actually active. She's a real estate agent and is working while she's getting treatment. Our duration of response is actually pretty good. This is also ongoing. The median duration is about 6 months. At that time, it was 1.8 to 12.9 months. This is the time of this analysis. Since that time, it's actually longer. It's closer to 20 months. And this is where we're also excited. Look at liver metastases. Confirmed partial response rate of 39%. In patients who've had checkpoint failures, it's about the same rate. So checkpoint naive patients, it's 35%. Prior checkpoint, it's 37%. So it doesn't matter if you've had checkpoints. The responses are about 40% overall. This is our PFS. It's about 5 months, as I said before. And our overall survival is about 14 months. And again, these are both patients who are both checkpoint naive as well as checkpoint experienced. So where have we gone with this? So we just completed a phase 2 study that is for accelerated approval. I hope that we're submitting this to ASCO for presentation. I hope that we get this accepted. These are patients who have been platinum pretreated. We are also still looking for patients who are cisplatin-ineligible, and that's still accruing. Of course, you would want to combine this with checkpoint inhibition therapy. We have a phase 1 trial that is going on right now, combining Enfortumab plus pembrolizumab. We have one incredibly dramatic response in liver at this point. And that certainly makes sense because of the fact that this drug does tend to work in liver. And then the phase 3 trial is actively accruing patients that's open here as well as in our care centers. And this is going to be the registration trial that hopefully confirms the phase 2 study. So is this the only drug that we're working with? No. This is Sacituzumab govitecan. So this is a different warhead. So it's recognizing something called a TROP2, which is an epithelial antigen that's expressed in a variety of different tumors. And it's a slightly different linker technology, but it's delivering SN38, which is a topoisomerase 1 inhibitor. So it's a different drug. So theoretically, this should have activity in patients who should not be cross-resistant with any of the other drugs that we're working with. And right now, we're doing a phase 2 trial with Sacituzumab govitecan. And this is, again, based upon phase 1 and phase 2 data. This was a broad phase 1, phase 2 trial in urothelial carcinoma. This is, again, something we collaborated with the GYN oncologists on. And in urothelial carcinoma, this is the first cut of the data. Scott Tagawa presented this at ESMO last year. Again, these are a very similar group of patients to the Enfortumab Vedotin. Little bit different adverse events. Febrile neutropenia is present in 15%. We really don't have febrile neutropenia with Enfortumab. Diarrhea is also more prevalent, same as neutropenia. But we also see objective responses. 50% response rate, again, similar to what we saw with our other drug, but a small number of patients. And survivals, small number of patients, again, similar to what we've seen before. So we're looking at this drug in patients who failed Enfortumab Vedotin, and I think, again, there's exciting activity. So think of where we were in 2012. We didn't have checkpoint inhibition therapy. We didn't have targeted therapy. This is a collaborative effort amongst all of us, medical oncologists, urologists, radiation oncologists. You know, Tom Lynch was saying that Yale Cancer Center is the best place to be, and he was really building this place up. He wasn't exaggerating. It's actually absolutely right. This is the best place to be as far as urothelial carcinoma is concerned, because we're working with all these particular agents. And again, I thank all of my colleagues for their support and our collaboration. So multiple targets are being evaluated for targeted therapy for urothelial carcinoma. Anti-angiogenesis therapy combined with docetaxel improves progression-free survival, but does not improve overall survival. Checkpoint therapy is considered second-line therapy and front-line therapy in selected patients. And then Enfortumab Vedotin, as well as Sacituzumab, has activity in the second line. I'll stop there and take any questions you have. Thank you. Mike.
That was phenomenal. Thank you very much. Cell-1 assay here.
So I believe we use the SP243, correct?
We're actually using the 22.
22? Right.
But they're equivalent in data RIMS data.
Yeah.
Right. And we're using the combined score. So we're scoring both.
Can you include a companion approval for a PD-1 axis agent?
Companion diagnostic.
Yeah.
So I think we're going to have to see what the phase 3 data shows us. I think that's really going to be crucial because, you know, the FDA came out with this alert. You know, the problem with PD-L1 staining is that if you look at lymph node and you analyze the lymph node in different portions of the lymph node, you're going to get a different answer. So how much PD-L1 staining is really necessary? That's why the bar set so low on the threshold. The other thing too is that it's an acute phase reaction. So I would argue that a patient who's seeing chemotherapy is going to have a totally different expression pattern than somebody who's chemotherapy naive. And perhaps the reason why there was the lack of correlation in that trial is in the front line, you've had no other treatments to confuse you as to what's going on. And chemotherapy does cause an inflammatory reaction. In fact, one of the arguments as to why chemotherapy works is that you do incorporate immune cells to clean up the cellular damage that you induce with these agents. So, I think the jury's still out. Maybe Peter's got some more thought on PD-L1 staining.
So we've been doing it here for I guess year or two now. I think there are some challenges in interpretation, especially assessment of the inflammatory cell population. But nevertheless, we can generate a score that's, as Dr. Rim has shown in that gamma oncology paper, that's pretty reproducible.
What about the importance between the tumor of the bladder and the but we're not sampling any of them the metastatic.
We've done that to some degree. There seemed to be a correlation, but the numbers that we've looked at have been so small. So again, I forgot to mention about how great collaboration we've had with pathology over the years, and Peter's been great. Peter Humphrey's been great and helped us with these particular studies. But
I have one more question.
Yep.
Also. So, and then see the age distribution. Most of the trials, median age 67, 69, probably representative of the normative distribution of that bladder cancer. But we see patients in their 80s. Is there any reason to think they, based on age selection alone, they should be approached differently?
so there have been, clearly if they can tolerate chemotherapy, that's a selection factor to get to that particular age. That's again why we're looking at some of these immune treatments earlier. You're not getting the same severe neutropenia that you get with chemotherapy. So again, when I made that little caveat about PD-L1 staining with a platinum-ineligible patient, if they're not going to get chemotherapy regardless, forget the PD-L1 staining, give it a shot. 11% of patients who are PD-L1 negative will respond in the Atezolizumab studies. So this is where the huge contradiction is.
So are there clinical trial data available on checkpoint inhibitor treatment, very common carcinomas, especially the ones that are so aggressive, micropapillary plasmacytoid?
Nobody's really looked at that. I've had a couple of plasmacytoids that have blown right through PD-L1 therapy. So nothing seems to work on those patients at this point. There is, what we're seeing in these randomized trials is there's a subfraction of patients, probably about 5 to 10%, blow through everything. So that phenotype is something we really need to identify and figure out what's going on. Yes, sorry.
Thanks, Dave. Great talk. I have some questions about the non-muscle invasive bladder cancer refractory group that we're referring here. So one thing, like wonderful benefits of non-muscle invasive bladder cancer is that usually we do a lot of localized therapy, BCG, vesicle therapy. And when we're looking now, it's systemic therapy, right? With all the associated toxicities that are huge costs. Is there any role for vesicle agents, for example, injection into the urothelial, or some sort of other kind of way of localizing this therapy? I know there is data on that for melanoma.
Right, injecting directly into the tumor cell. Nobody's looked at that. I'm trying to convince Seagen-X to do an intravesical trial of Enfortumab Vedotin, which I think would be the perfect thing to do since that drug has such great activity. No, I think that people are looking at vaccines, viruses in that setting. There's an adenovirus that's being looked at. So I think that it's a reasonable thought, limiting the systemic toxicity. We'll see where the PD-L1 goes in the future. Thank you. I appreciate it. Great presentation.